Good afternoon, everyone. Hello. Hope you can hear me okay. We've got a bit of a rainstorm appeared out of nowhere here, so if it sounds like thunder on the roof, that's because it's probably is. Hope you can hear me all right. So thanks for joining this Vivek webinar on deconditioning and the importance of mobility. We're pleased to have with us here today Sharon Rindsland, who's for the board of directors of MBE, also trust-wide moving and handling senior coordinator at East Kent Hospital, and is the CEO of RQS, which is recognizing quality solutions. So just before we get started, we're going to run through a little bit more about us for the benefit for those of you who haven't met us before or heard about us. So we've been supporting the healthcare industry for over 50 years, originally as Yorkshire Care Equipment, which is a name that some of you might be familiar with, but we rebranded in November last year to Vivid Care. Still the same people, same great service, same mission, which is to enhance the quality of life, which I'm sure will be resonate with all of you here on this call, because that's our core purpose here. So deconditioning is a fascinating subject, something that I don't know much about, and very much looking forward to learning more about it. However, we do know the importance of getting people up and moving, and we have a number of products to help with that, from the more standardized recline chairs, although ours are built to be adjustable and fit all patients really, but there is also chairs which can lie flat to help people get out of bed and then gently bring them into a seating position, and then right through to activity chairs which can be used with the things like MotorMed and things like that to help people learn how to do exercise again in a controlled and safe manner. So with that, I am going to hand over to Sharon now, so that she can take you through her slides, and I'm really looking forward to this. I'm very interested in hearing what she has to say. Thank you. We'll be taking, I should just say, we'll be taking questions in the chat through the presentation, and then we'll come back to those at the end and put them to Sharon. So Sharon, over to you. I'll stop sharing.
Thank you, Graham. I'm just going to share mine. Can everyone see that okay?
Sorry, Sharon, couldn't hear you just then.
Oh, can you hear me now? Don't know where the sound's gone.
I can hear you, Sharon. I think it must be on Graham's side. I can't currently see the screen though.
You can't see the screen?
Not at the moment. Maybe that's me. Let me just have a look. No, I can't seem to see that. Do you have you used the share button at the bottom?
Yeah. Let me come back out and do it again.
Yeah, might be wise. Sorry. Thank you.
That's okay. So I'm going to do it again.
Brilliant. That's working now. Thanks, Sharon.
And then see that fine?
Yes, perfect. Thank you.
Not sure what happened there. Mind you, me and IT, not the greatest thing to be together. Good afternoon, everybody, and thank you for inviting me to do this talk for you today around deconditioning and the importance of mobility. I'm very passionate about what I do, so hopefully that will come across, and really happy to answer any questions that we said at the end. And also, I'm also interested to learn from you as well. So please, I don't know everything. I'd like to think I do, but I don't. So going forward, hopefully we're all going to learn something from this. So today's session, the course content is we're going to be looking at the patient mobilisation. It is a real hot topic at the minute, as we're all aware, whether it's community or trust-led. We've got an awful lot of issues around the amount of patients we're seeing. So trying to keep these patients moving and keep our hospitals free and our homes and environmental areas safe for our patients. So that's crucial at the minute. So we're going to be looking at the impacts of falls, the cost of immobility, that pajama produced paralysis. So we're aware of the ones that will come in hospital and assume that we are actually going to move them. And we're also going to be looking at the importance of patient assessment. And that's one thing we do fall down on, because we complete assessments but don't complete it correctly sometimes. And therefore, the knock-on effect of that ends up causing issues further down the line. And when we look at legal documentation as well, it comes back to bite us in the bottom, because we've not dotted the I's and crossed the T's. So we're going to be covering all of those today through this webinar. So the objectives is we're going to be looking at describing the causes and the effects of immobility and understanding the importance of mobilisation. And when I say that, how it affects and what actually our patients can do for themselves, but a lot of the time we take it away from them. We're going to describe and conduct a patient mobility assessment, and we're going to be looking at assess patients' level of risk. Importance of using the right equipment. Now that's the fundamental part of this, I personally think, because there's a lot of things changed. And if for any manual handler out there or OT therapist, you know, manual handling has changed massively, because once upon a time we were the handler. Today we're not. Using the right equipment can mobilize our patient a lot better. So that is really, really fundamental to what we should be looking at. So mobilization defined. So we're all 100% aware that it's the physical activity that's performed by the person. So that could be anything from a patient that's been comatose and is being mobilized for the first time in ITU. We're just on the back of COVID. So most of you will be 100% aware about this, how sick our patients have been, muscle loss, weight loss, and we're now getting them out of bed for the first time, or even getting them into a chair. Also right down to the activity from a bed. So that's rolling and turning and just getting out of bed to transfer maybe to using a Zimmer frame. What makes patients immobile? So I'm sure you're 100% aware that what makes our patients immobile when we start looking at the physical factors is the pain, the critical illness, like surgery, fracture, hip. You know, the psychological factors are what actually happens to our patients. Well, we're all aware of this. When a patient falls, that patient becomes less confident. The fear of falling again. And that contributes to more falls, because this person's not walking as, I mean, I'm sure you've all done it yourself. How many of you have been out for a walk and it's been a bit icy out? I know I do it. My husband says, why are you walking like that? It's because I'm petrified I'm going to fall over. So our patients are exactly the same, and that makes them more prone to falling. Effects of medication does it as well, doesn't it? So we change medication constantly, so to get that medication right to make that patient better, but the side effects from that could make us blood pressures plummet a little bit, or it could be just generally making that patient feel a bit unwell and a bit anxious. Sometimes it's environmental factors as well. So if you have got someone in hospital who've never been in there before, they're away from home, they don't really want to be in there, and they're fit, you know, they are anxious about what's happening to them. So all of those factors, and the concerns about the loss of dignity, the stigma attached to the use of specialist equipment. So we see that with our bariatrics. We quite often get bariatric patients who say, I'm not going in that bed because it stands out, and they look like the big person in this big bed and everyone's looking at them. So it's defining that and actually trying to change it, but still treat that patient with a bit of dignity and respect. The effects of non-mobilization, well, short-term bed rest, decreased muscle mass, bone density, and body impairment. So it's so quick. That's only just short-term bed rest, but prolonged bed rest. And this is when I was doing my research, and I've just on the back of a master's, so did a lot of work around this. People, 80-year-old for argument's sake, lose 10% of their muscle mass every 10 days spent in hospital. That adds 10 years of aging. That blew me away a little bit, because how many of you have been a bit unwell or, you know, it could be that you're on the back of COVID, you know, we've got this long COVID and everything else, and how it makes you feel. Can you imagine that if you've had surgery and you're just getting up and mobilizing and moving around, and there's and you've got to get up for the first time, how your muscles are feeling, how much weaker. And as you're older, that gets a lot slower because it's part of the aging process. Rehabilitation takes twice as long once we lose it. The muscle loss is phenomenal. Some people never ever recover. And that's really, really sad, because the consequences of that, it's changed their whole life. Supporting patients to mobilise. Early mobilization is a fundamental recovery and a pivotal in nursing role. There's a lot of people out there who say that mobilising patient isn't our job as a nurse. It's not, it's a physio's job, but it actually isn't. It's everybody's job, because if we don't keep that patient moving, you know, they are going to decondition. And when I say that, if, you know, something as silly as raising their arm up to push the button to sit themselves up, or moving themselves up the bed using a slide sheet under their bottom, this is keeping that patient moving. Patients laying in one position, chin in chest, airways restricted, blood pressure plummeting, they're not drinking or eating properly, they're deconditioning all the time they're in those positions. So it is keeping that patient moving. Pressure, they end up with pressure ulcers and things like that. We're 100% aware that if our patients are on a standard foam mattress, it may be they've come into hospital and they don't need an active mattress at the time, but they've been in A&E for the last 24 hours because our A&Es are so full that we can't get them out in the wards. So now we've got that deconditioning happening straight away. The skin is starting to break down. The effects of that can end up with bladder and bowel dysfunction because this patient's not moving. And again, if we reflect on that ourselves, you know, when you felt unwell and you've been in bed a few days, it happens to us. You know, you're not, your body's not functioning as it would normally. It might be that every day you get up and you go to the bathroom at a certain time, but suddenly that's not happening because you've been bedridden for the few days. So your body's just lost that function. You've got to teach it again. Respiratory problems, when I just mentioned that, when, you know, our beds are not positioned properly, or the patient's been laying in bed for periods of time, so their chin is in their chest, they're hunched over. I'm sure you've all seen that, whether it be in a hospital ward, even if you've gone into someone's home, they've got too many pillows and we're expecting them to eat and drink. We suddenly stick them on oxygen because we think their sats are dropping, but that's possibly just down to the way they're positioned. Their blood's not flowing through their body as it should do because of the way the backrest's pulled up. Deep vein thrombosis, they're not moving around. The body's slowing down, everything's slowing down. Mobilization is the insufficient mobilization is one of the biggest problems that there is out there. And there's a massive, massive push around this now to make those changes. The biggest things we're up against is how many patients we've got coming through. So we need to change the way we're thinking and about how we're moving these patients forward. The cost of immobility. So when a lot of us, we always talk about, we can't afford the equipment. You know, the trust haven't got that sort of money. But when you look at the cost of what it would cost someone to stay in hospital, what the cost would be for that person who has now got a life-changing condition that they didn't have when they come in hospital. You look at the quality of life and you think about the legal cases that you might come across with that, because that patient says, when I came in hospital, I didn't have that at all. The high mortality rates. Do you know, it costs 400, it's more than that now. I think recently it's just gone up to £475 a day to stay in hospital longer than they should do. So it increases the length of stay because the person can't go home and look after themselves. We're also aware that at the minute we've got this big problem with our discharge programs, because you know, our communities are trying to do the best they can there, but not having the staff like we have in the hospital to manage these patients with 2, 3, 4, or even 5 carers, because we've not had the equipment to do so. So the backlog of that is actually going to end up almost like not being able to move our patients forward to get them discharged. So we end up with this bottleneck inside a hospital because we're not having it. And as I said, I briefly talked about this earlier on, that pajama-produced paralysis. And there was a big NHS campaign recently about encouraging early mobilisation through simple interventions, such as encouraging patients to get out of bed and get dressed, and lead to reduction of falls in pressure ulcers. It shortened their length of stay. Now, this was done back in 2018. So everything I talk about with you today is all referenced. So you can actually pull some of those references at the end of these slides. And I'm also happy for these slides to be shared. Mortality levels during and after acute illness also have been linked to risks of early hospital readmissions. For example, older people readmitted within 30 days were found to be walking about 1/3 less than the patients who were not been readmitted. So it's all linked to that in those pajamas, and possibly looking at it's our fault. You know, they're in hospital. It's our job. They pay our taxes. It's down to us to move them. And I'm sure a few of you have heard that saying before. And I know I've had it when I started all those years ago, long before the dinosaurs. I walked on a ward, and I remember this patient saying to me, you know, I pay your taxes. This is what you're paid to do, as if it was a 5-star hotel. So it's actually changing the way we think, but without the patient thinking, well, actually, that nurse is lazy. She doesn't do anything. Because I've also heard that saying of, actually, I'm not paid to hurt my back. It's down to you to move yourself. But it's about working together and getting that patient mobilised. Introducing an assessment mobility. Now, this is something we use quite a lot. So I call this my patient mobility assessment. And it's a plan that you're probably all familiar with in some shape or form. It might be, you call them care plans. You know, as one of the directors of the National Back Exchange, most of my stuff that is taken is what we class as a standard through the National Back Exchange. So if you're not a member of the Back Exchange, it's worth thinking of getting yourself linked into, because there's a lot of advice and support out there through it. But the benefits of mobilisation is to plan a patient's care. Now, this is from when they come through that front door. So we should be looking at a risk assessment score and understanding. And I love these mobility galleries. So these mobility galleries, so this one itself is from the Arjo Mobility Gallery that I've used here as a reference. But you know, when you start looking at, and I love pictures as well, because we work with very, very different language barriers and different nurses across the world now coming into our hospitals and our acute cares. So having pictures makes a difference. So when you're looking at an assessment, you should be looking at what's the complexity of the patient. Can they move on their own? So what sort of conditions have they got? What sort of weight are they? Are they able to lift their legs up? Are they able to move their arms? All of this makes a big difference when it comes to scoring. An assessment must recognise the movement and the function and the individual patient requirements. Now, we shouldn't just assume that all patients move the same, yet no matter how many times I teach this assessment, and this is in our own trust, no matter how many times I teach this assessment and indicate why it is important to have it documented clearly how your patient's moving. And the reason for that is, if you're on, say, Sally's on duty today, and then tomorrow you've got Debbie on duty, if that assessment's not completed properly, someone's then picking it up and saying, well, this person's independent. You know, I've walked on a wall before now, and I've picked my assessment up and it said patient independent. And it's got it as the green bar with the gentleman there, you can see, standing up, scored as independent, less than 5. And yet the patient is sitting on a hoist-sling, which is pretty worrying. So the assessment is paramount to the importance of getting your patient moving. The assessment requirements, it needs to be accurate. It needs to make sure it takes into account the patient's needs. It should be completed on a mission. So as soon as it's done through that front door, you can start planning what equipment you might need. The assessor should be able to complete the assessment either electronically or at the bedside. Now, there's a little bit of an argument over this bedside and electronically. If I'm honest, I know everyone's trying to go paperless, but how many of us get a chance to go over to the computer if you haven't got handheld devices to check that? So we are still by the bedside at the minute, only because I'm a bit of an argumentative monkey in the sense of I really am keen to make sure everyone's following that guidance. Until they can give me a device that proves that everyone can access this in front of that patient every time they want it, then I'm not happy to sign it off, because you do need to be able to pick this up and you need to be assessing it and looking at it. If your patient's completely independent, then you might want to do an assessment and review that assessment maybe every other day. But if your patients come in, say, and come in for surgery, then you might want to reassess it the minute they've had surgery, because they could have come in, they've walked through the door, they had a knee replacement, and they may be struggling to move around. So we need to be looking at it in those ways as well. The assessment would ascertain whether the patient was independent or require assistance, and if they do, what sort of assistance do they need? What sort of equipment do they need? It's really important that you document as well what equipment they're using. When it's completed by their bedside, you might be looking at, on our assessments itself, on the toolkit, which is the second page down, it starts looking at, if we look at the activities that you might be thinking about, repositioning in a chair. Now, there's lots and lots of different chairs out there. We know that. We have a standard hospital chair, but that's not always the right chair. You know, depending on the patient's shape, size, depending on their abdomen. We have patients who are bariatric, who've got a large pannus. So I've seen a pannus of 7 stone before now. You really wouldn't want to be sitting that patient in, as you can see in my picture, in that chair, because their pannus is going to be hitting the floor, and trying to mobilize that patient is going to be a bit of a nightmare now. So your assessment has got to identify what sort of equipment you're going to be looking at. So sitting and standing, you know, we don't all stand the same. It drives me mad when you get people who are robotic to say, actually, this is how we stand up. And you have someone, you know, saying 1 foot in front of the other one. Well, not all patients stand that way, as long as you've got a good, stable base. How do we know that patient's strong enough? So you can see in the picture that one of my staff is actually testing for strength to look at upper body. So that would all be indicated in your assessment. Positioning, turning in bed. So a lot of our patients struggle to turn over in bed, but a simple slide sheet under the hip can actually enable that patient to turn themselves and then remove the slide sheet. So these simple measures of how we can score that patient without making it too complex is really, really important. Even right down to our patients getting out of bed. Most of us in an acute trust, and sometimes even in the community, if your equipment store and your assessment has identified that this patient's mobility is so low, you need a powered bed for height-wise to get your patient out. Utilising and teaching the patient how to use the bed to enable them to stand can have massive benefits for our patients. So when we're looking at the level of dependency, 4 levels of dependency options were given. So independent, which we talked about our gentleman in that picture, if you saw that right at the beginning, you know, he's standing there, he's quite independent. He might walk around with a stick, but he's getting in and out of bed himself. So that would be classed as quite low on my risk assessment, although that doesn't mean to say I wouldn't reassess just in case his medication has changed. It may be that the medication's got side effects, but he doesn't want to say anything because he doesn't want to cause any upheaval. He's concerned that the nurses are running around like headless chickens, and he really wants to keep it quiet. So he's feeling a little bit unsure. Within my role as well, I actually sit on a board where we look at accidents and injuries. And some of the accident injuries are from falls, are from very, very independent patients because their medication has caused a little bit of an upset, or they've got suddenly a postural drop. So don't always assume just because they're independent, they're going to stay that way. Supervised, well, that sort of patient. So we're starting to move up the scale. This patient can stand, but they've had a few falls. They're really concerned that they're going to fall again. So they're really not sure, but we don't want to take them away and put them into that dependent mode. We want to try to keep them moving. So we want to try to mobilize, but staying with them. That might be using a piece of equipment. It might be using a Zimmer frame with wheels, whatever it is, but you're trying to keep them up and going, and then you start moving into dependent. Again, that doesn't mean that person's not doing anything. When we say dependent, yes, it might mean that we're taking them out into the bathroom using a mechanical aid, or it might mean that we're moving them up and down the bed with slide sheets. But what we're also doing is we're asking them if they can bend their knees. So we might be moving them, but we're still trying to get those legs moving. We're still trying to get their head moving. We're trying to encourage them to breathe and oxygenate those muscles. And then we move to hoisting. Sometimes as well within a hospital, and I've seen this many times, we take their independence away completely because we're hoisting. Yet sometimes our patients hoist themselves at home with their wives or their husbands. So why are we doing that? As long as our patients are compos mentis, we give that patient that handset, show them how to use it, and have that other handler making sure that that patient's got the sling properly. They might need 2 handlers to put the sling on, but when it comes to going from A to B, as long as someone's with them, why are we moving that away? Why are we taking that away from them? When we start looking at it like that, we can get our patients moving a lot quicker. So complex needs, outcomes of the assessment can be greatly affect the complexity of our patients' needs. For example, we talked about medical conditions, the effects on medication. We talked about the falls risk, and we talked about low blood pressure just then. Poor eyesight. Now, one of the falls we actually discussed this week on a fall was actually a patient whose glasses needed cleaning. So, I wear glasses when I'm working on computer, and my glasses get just as bad as everyone else's while I'm sticking my fingers all over them. So if you've got a patient with actually poor eyesight and has got maybe a bit of glaucoma coming, all of these affect, our wards are really busy. We've got extra bed spaces in there. Someone's brought the linen trolley in there, the commode's in the way, or they're in a strange environment. All of these affect the fact that they could fall. They're not sure where they're going, and they're trip hazards. Unsuitable chair, that's the big one. And that's quite frustrating because they can't reach the floor. The chair looks lovely. It color codes with the rest of the ward, and it color codes with their bedroom, but they can't really get in or out of it. So they're less likely to use it. So risk rating, you're all familiar with the risk rating. We're looking at a low risk. So no immediate action, but as I said with that gentleman, we need to keep watching. We need to keep looking at what it is. Just make sure that in and out of bed without a chair assessment, because our patient is okay where they are, they're quite safe, they can get in and out on their own. Then you look at the medium risk. We state that someone level of assistance. So there you go. That was that yellow one that we talked about. Needed prompting, need a bit of support. Look at and reflect this on the care plan. So on that, or care plan, risk assessment, patient mobility, in my case, you would write that this patient stood up with one. Strength test was tested to check arm and leg strength. And when you're asking them simple little questions, like getting them to shuffle forward so their nose is over their toes before they stand, I see that massively when it comes to getting our patient in and out of a chair. Many of us wouldn't stand sitting with our bottom as far back in the chair as possible. We would actually slide forward to make sure our knees were over our toes before we stood up, to make sure for our weight was in our feet. And the high risk would be the support equipment, which is required to reduce that level of risk. We can bring our high risk red patients down into the amber, and sometimes right the way down into the green if we start to encourage our patient to use that equipment and understand that equipment themselves. But majority of us are so busy, we lose that. We don't understand that. And we don't mean to. We don't set out to hurt our patients because we have that caring nature, but it ends up that way through deconditioning. So our chair, this is a big passion of mine, our chair mobilization. The wrong chair, trying to get our patients in and out of a chair. We've also got patients out there who prefer to sleep in a chair, and then they come in hospital and we sit them in a bed. Now, I totally understand we can't go letting our patients all sleep in beds, but if there's a patient who functions better from a chair, why are we changing that if we can get them in and out? When we look at mobilisation and assessment of a chair, we should be looking at, do they stand up? Can that patient sit up properly? Can that patient drink quite comfortably? Can that patient, is their weight central within that chair they're sitting? Is it easy for them to get in and out? Can I put a hoist around that if I needed to, or can I lay it back so that I can laterally transfer if I needed to? Once you get that right chair for a patient, it changes their whole outlook. If you look at dementia, for argument's sake, dementia patients love security and love support. My mum had dementia. You know, trying to get my mum out of a chair sometimes was very, very difficult. But I always remember trying to get my mum to move forward in a chair so I could stand her. I remember talking to her about the can-can. Couldn't remember what she had for dinner, but knew exactly what the can-can was. So she'd kick her little legs out till she slid forward enough for me to be able to stand her. So chair assessment and getting that right equipment and working with our therapists to get that right equipment is so important in regards to mobilisation. And I am so passionate about that. There is such good equipment. This wasn't around in, years ago, and it is now, and we should be encouraged to be using it. And it drives me mad when we get told, well, there's no funding. There is funding. You need to be looking at the right avenues to go down. And I'm more than happy to ever support anyone that needs that. So impact of falls and sliding from a chair, broken bone, bruising and wounds. It knocks people's confidence. It affects their dignity, doesn't it? It's as bad as for us, isn't it? How many times have any of you gone somewhere and you've slipped out of a chair and you feel a right idiot and you've got yourself up and you're looking around? I know I've done it. I remember going for an interview once and sitting in the chair talking to the people, and I was so nervous I slipped out the chair myself. I don't know what I thought. Well, I failed this interview. This ain't happening, and I actually got the job. So I don't know what it was I did. They either thought I was a human being, or they probably felt sorry for me. I'm not quite sure which. However, it does affect you, and it does make you feel not confident with regards to moving. Your pressure injuries when you've got the wrong chair. So if you can't move, you're sat in one position for periods of time. You can't move yourself. The wards are really, really busy, or the carers have been in to see the patient at home and they're not coming in for another 3 hours. So the patient's sat for prolonged periods. I'm not sure who I've got on the call today, so I apologise if I'm missing anybody out here. But if you think in an environment, we do see this quite a bit as well, that someone at home has started to put a little bit of weight on because their mobilisation's got less. They find that we all do it, that we're eating a lot more because we're sitting in front of the TV. We're not active as much as we should be. So our muscle tone is reduced. Our muscles have got weaker. And basically, as that patient is sat there, we're finding they're not even getting up and going to bed anymore. They're staying in the same chair because they're struggling to get out of that chair. And that's really, really sad, because sometimes we have patients that will come in with huge, great pressure ulcers due to the fact that they've been chair bound, and it's nothing to do with the care. It could be that they've not even got a care package in place because they haven't needed it up till then, but they've been sat in that chair for so long. If we could change just a part of that, and we could actually reduce the amount of times our patients become unwell and get admitted into hospital. Delay in rehab. That's across the board. You know, we have our own problems where we are so busy. We have got so many patients. Our A&Es are absolutely full, where we've got beds in there and not trolleys. We're trying to bring our patients through the hospital. We've got extra beds on our ward, and the discharge at the other end is breaking down because we can't discharge them because it's 3 or 4 carers and there isn't space in the community at that time. It's not for the want of trying for everybody across the board. Those are the issues. So if we look at the rehab of that patient from the minute they come in, to lifting up the arms, sitting up properly, lifting of those legs, eating properly, drinking, opening their bowels, all of these massively impact our patients for deconditioning. And sliding from the chair is one of the biggest ones. So getting that chair right, measuring that person to that chair and making sure they're comfortable, and just silly little things by asking the patient, show me how you stand from this chair. If they're standing, you're on a winner. They're moving, they're getting them up and about. So the manual handling risks, the need for constant repositioning due to a patient sliding in their chair means the increase of staff. So they're not moving on their own. They can't do it by themselves. It's an increase in MSDs as well for us, isn't it? Because we are now physically, no matter how many times you've all heard, I'm sure, the drag lift, you're all aware 100% of underneath the arm is classed as the drag lift. I like to call it controversial, don't like to call it condemned, because there's a chance I might do it if someone was choking and I put my arm under, pull them forward to get that airway clear and open. But we injure ourselves, so we're in positions, you know, we run training sessions all the time, like most of you do, I'm sure. And yet we talk about this drag underneath the arm of dragging someone up and out the chair. We don't set out to hurt our patients. We don't realize, because we've got our patients in mind, that we're actually injuring ourselves. But that repetition of having to move this patient because the equipment isn't right ends up on the impact of us. Now, we are seeing an increase of MSDs, which dropped massively, but on the back of COVID, MSDs are increased. So I'd like you to think about this for a second, and at the end in the chat, let's have a chat about why you think they're increasing. What do you think is causing it with regards to the COVID and the repetitive handling side of it? So how to reduce falls and sliding from a chair? Well, we've said proper seating assessment. I talk to our physios and our therapists, our OTs all the time. I work very, very closely with my OTs. It is important that we work together, that I work very closely, not with just OTs, on my tissue viability, my falls, my infection control, my nutrition, and my bowel areas, and also my end of life and last offices people, because all of these have a massive impact, not on staff, not on just staff safety, but our patients. Every patient deserves, right up to the very end, the best treatment they can. So looking at supporting posture and function drastically reduces the risk of the patient sliding out the chair. We all want to feel like my lovely picture sitting there, that I feel quite comfortable and I feel quite happy. Remember, using the right chair will enable the patient to mobilize longer and reduces repetitive handling. It reduces the patient's deconditioning. It improves mobilization. So nurses, you know, spend 20% of their working time patient mobilizing and handling tasks. Having the appropriate equipment can reduce that massively. Equipment can reduce how many staff are needed. So I just want you to think about this for a minute. And someone said this to me once, well, what do you mean it reduces the amount of staff? If you look at on obesity, for argument's sake, you can have a patient that's admitted to a hospital, and it could take the heaviest patient we've ever had is 69 stone in our hospital. And I still like stone, sorry, that's how I like to work with. But, you know, 8 or 9 patients to move, 8 or 9 staff to try to move and mobilize this patient. This patient's deconditioning very quickly. So having the right equipment, having the right gantry, having the right chair, you know, we can get this patient with a gantry and the right equipment beside that patient. We can reduce the 8 down to 4. And then the more this patient's getting used to using standing frames, the more this patient's getting used to support vests, this patient is increasing their mobility. The more we're using turning aids, the more we're using a chair where this patient can sit upright and can actually move or turn themselves, we're reducing the amount of staff we're using. That's what I mean by equipment and reducing our patients and increasing our patients' mobility. It's important that the manual handler, and this isn't a dig at my manual handlers, because I know how it feels. I've been doing this job now for 26 years, and I understand fully of the pressures that we're under. It's important that the manual handler advisor has the right knowledge and skill and understanding how they can work with others to get what they need. So many times I hear when I do talks across the country, and I've done talks across Europe as well, well, we haven't got time to do any of this. We're too busy training to get the right equipment in. Well, if you've not done your risk assessment and identified the need for change, that is never going to change. You're always going to be training. And now in our trust now, we've increased our staff. We have 9 staff that work for me because we've proved that the importance of being on the ward, the importance of getting equipment by every single bed. If the equipment is there and seen, people will use it. If it's out of sight, it's out of mind. We've worked with all of these areas. We've worked with all of these staff to ensure that they can use the equipment, and they know how to work, how to use it. They've got the confidence to teach others with it, and they work with all our clinical and nursing teams. So I can't push that enough, how important that is. Organisational barriers. I've said this to you earlier on. We've got organisation barriers. Our barriers are our mobility assessment. Is it completed properly? Regular assessments, not receiving the right level of support for equipment. So basically, as I've said, we've got our patients sat in a chair and they are in a hoist, and yet the assessment says that they are independent. And that's pretty worrying. Some of our organisational barriers are things like we haven't got enough staff. We haven't got time to fill that assessment in. That patient's going to have to stay in bed because we haven't got enough staff to move them. But what we're not actually looking at is the bigger picture there. This patient isn't moving because we're not spending the time to move them. Not having the right equipment for starters, that is a big one. And people often say to me when they come in the hospital, gosh, how did you get that equipment? It was a battle. I'm not going to lie to you to say, oh yeah, it was really, really easy, piece of cake. It was a battle, but I never let it drop. Risk assessments, documentation, proving its cost, proving what it's going to cost the trust. Actually, now they don't ask me those questions. If I ask for something, 9 times out of 10 will get it because they know I will prove evidence from it. And the final picture, those involved in patient mobility initiates report, reduces their workload. So it reports that if we've got the right equipment, it does reduce our workload because we aren't going to need as many staff. We're not going to need as much time doing it. We're starting to encourage our patients to use the equipment around us. Gone are the days where, for those of you that are as old as me, remember the good old Australian lift and the orthodox lift, where we physically, there was no slide sheets, there was none of these fancy chairs. I remember the hoist, even the one that used to wind up. That's how old I am. You know, we haven't got any of that today. We've got these fantastic bits of kit that you can push the button on. You push that button and you can get that patient sitting up straight. You've got lovely chairs where you push the button and it helps them stand up. You know, so why are we trying to stand them when we can actually do it that way? I think this is across the board, because I'm sure some of you are going to be putting in your chat and your questions later. Some of our equipment isn't fit for purpose. Well, let's look at it. How can we change it? Sometimes patients can be resistant to staff helping them. I know that. Some patients don't want the help, or confusion can stop a patient who doesn't want any support or help with that. So it's about what can we put in place then to change that? We cannot be the only person who has those problems. Other people must have had the same problem. So let's look at working together, find the right equipment, complete those mobility assessments, make sure we keep those patients moving, because deconditioning is all around movement. If that patient's not moving, believe me, it happens very, very quickly. So next time you're walking about and you see a patient who's in a ball in a bed, think how quickly that patient's deconditioning. The older that patient is, the faster that's going to happen, the longer it's going to take for that patient to come out of that. So that's the end of my presentation. Are there any questions? I'm going to stop sharing so I can see everybody.
That's brilliant. Thank you, Sharon. Very, very interesting, very enlightening indeed. Just a reminder to pop on the chat any questions that you have. There's not too many come in so far, Sharon, which means it was a very good and very full presentation. So one thing which I am interested in, your question that you posed around the MSDs increasing since COVID. MSDs, I presume that is musculoskeletal disorders.
It is, yes, and I shouldn't be using abbreviations. Yeah,
No,
it is that they have started to increase, and we don't know whether that. I'm going to be doing some research on it, if I'm honest, because I don't know what's happened to me since I've done my masters of suddenly researching everything. You'd never have thought that a few years ago, but we don't know whether that's on the back of proning, where we've had to prone so many patients. We don't know whether it's on the back of that we had a lot of sick patients and we were physically handling them. We're not quite sure, but it is actually showing there is an increase on it, and whether it was our own ability, our own self, maybe we weren't well enough, I don't know, but it would be good to see what the outcome is of that.
Yeah, very interesting. Has training continued, like manual handling training and everything? Has that continued through the COVID times, or has that taken a hit at all?
Well, us as a trust, we carried on training. Admittedly, we couldn't run the big sessions in our classrooms like we did before. So we'd have 10 in a classroom. So what we were doing as a team, every new starter that came in, we were going out in the ward to find them and working with them for a few hours, introducing them to equipment, making sure that they were safe. And what we also did was I myself went up into ITU for 2 days to look at what could increase musculoskeletal disorders. So for those, if anyone's online who worked in ITU, might have said, oh, that proning did my back in, my neck in, my shoulders in. So I was trying to look at what could have initiated that, and then coming back to the classroom and spending 2 days with my team, coming up with ideas what we could take back to ITU to see if we could. So we were trying to be proactive like that, where we couldn't have been before. And if I'm honest, it made our team very strong, because wards took us seriously and not like, oh, there's that manual handling team again. We become friends, if that makes sense.
Mm-hmm. Yeah, that does make sense. Yeah. Question just coming about, could you just explain about proning and what it is?
Proning is when our patients, nursing ITU staff have been proning a long time, and this is where our patients laying on their back, and it could be because of chest infections, it could be through breathing difficulties, it could be for lung expansion, that they want a patient over onto their stomach. Now, a lot of our COVID patients were proned, and they will be proned every 6 hours for up to, they were proned every 6 hours for up to 16 hours. So this patient needs to be turned over and have pillars onto their chest and their abdomen to open up those airways. And this was to enable that patient to breathe. So there's been a lot of research on that as well now, because they're now thinking, was that the best way forward? It actually probably saved a lot of lives, but there's a lot of questioning on the background. But it took 8 or 9 staff to physically pop slide sheets underneath the patient, wrap them what we class as, if anyone's done it, it looks like a Cornish pasty effect. So you'd have 4 people either side and a person at the head, turn the patient slide them onto their side, then fully over into a prone. And then they'd have to do it again 6 hours later to turn them back.
That's incredible.
Even the largest patients. So we've started to look at hoists in our areas that we're prone a lot in now. So we're actually doing it with repositioning sheets and proning to give us a better way of doing things. So absolutely stuff that I wasn't aware of, if I'm honest, opened my eyes massively.
Yeah, that's fascinating, absolutely fascinating. And you can understand how MSDs can increase in that type of environment. Question just coming about whether there's any good examples of research about preventing deconditioning in care homes and in the community. Have you come across that at all in your research?
No, but my papers were on, because obviously I did mine around a trust setting because I wanted to buy equipment. But I am sure there must be a lot out there, because if you think of our a good search engine, if I'm honest, I always just go into Google and write Google Scholar, and if you write deconditioning community or care community or care home community, I'm sure something will come up, because you can't tell me that there isn't a huge number. My mum was in a care home, bless her, up until her last days, but I remember going on there and the amount of patients just sat in the chair and not moving. you know, it's got to be there, and someone's got to have done a paper on it. So you've got my mind boggling now. So I'm probably going to go and have a look myself, if I'm honest.
That's brilliant. Thank you very much to Paula for that. A question coming about who in an organisation would families speak to about concerns of deconditioning, to do with how many patients who come in ambulant but go home non-mobile? Is there anyone in particular in a trust that would be good speaking to?
Patient safety.
Patient safety.
I sit on the patient safety board. Did you know, I'm going to be honest and open with this. When I first started tackling deconditioning, the importance of equipment, keep our patient mobilized, it was falling on deaf ears. It was almost a bit like with manual handling. You know, manual handling wasn't invited to fundamental meeting. Manual handling wasn't invited to patient safety. Manual handling, they weren't interested, because it was almost a bit like manual handling is all about stopping MSDs, because it musculoskeletal disorders, because it's all about protecting staff. Yes, back in 1992, it was all about that, because we didn't have equipment and staff were being injured. Today, it's all about staff protection, but high patient protection, because manual handling can cause so many patient injuries without realizing it. And I'm doing a huge talk on this at the Excel Centre in April for Patient Safety Board, because they've gone, oh, yes, you are at the forefront of injuries. You are at the fore. Just standing someone incorrectly from a chair because the chair's not right, we injure them. Whose fault is that? And we don't look at blame, but it can contribute that blame. So it is, I always go patient safety now. If I can't get my own way, I'll flag it. Oh, there's a bit of a risk to a patient here, and their ears prick up. Oh, let's look at this.
That's very helpful. And from your research, is there any particular areas or wards where deconditioning occurs the most in hospitals? Yeah,
if I'm honest with you, you're looking at a stroke, very, very quickly in stroke, and frailty. And yes, we've said frailty is because our patients, it happens so quickly within frailty because of our age now, and everything's slowing down. We're all the same, aren't we? No matter what age we are, if we're feeling a bit fatigued anyway. But in our our system's slowing, our body's slowing down, and we've been bedridden for the last 4 days. And yet before that patient came in, they were walking around. Now they're going to lose that. And also around obesity, it is huge deconditioning in our obesity patients.
Very interesting. Yeah. Have you come across in your equipment any tilting beds, and do you have any thoughts on those in terms of helping patients?
I absolutely love them. Absolutely love tilting beds. And the reason I say this, I actually now start working with our discharge teams around, because we have tilting beds in. And the reason for that is, if you've got a patient, the biggest problem we have is if you've got a patient you need to mobilize who's in so much pain, you're going to have restrictions there. So for argument's sake, if you look at rolling and turning, trying to turn up or get a patient to turn over on their side who is in pain will struggle. So they're less likely to want to turn on their side. So if you have a tilting bed that actually tilts them for you, that's taking that off. And I can honestly say, I'm going to say this with pride, if I'm honest. We had a lady who came into hospital. She was in so much pain, bless her, refused point blank to move. She had this grade 3 pressure ulcer on her sacrum. So we brought a tilting bed in to increase that mobility, to turn for her. And this patient then started to improve. She started then to manage it herself. And then eventually 3 weeks she was discharged. And the positive side of that, her husband donated so much money to the trust. We bought 5 new tilting beds. And I had a lovely letter from her to say, thank you. That prompted our charities to buy us even more. So we bought quite a few of them. Only palliative care, I can't say enough about tilting beds, because if the patient's struggling, get a tilting bed. You're still mobilizing, you're still moving. It's going back to that same as that chair thing, though, isn't it? If your patient's sat upright and they're really uncomfortable and they've got pressure ulcers, they've got all that blood flowing down to that broken area and they're not moving. Taking that load off by having that tilt and space is enough to change a position and enough to take the pressure off. I'm sorry, I get really passionate about it.
No, it's understandable. It's incredible, absolutely amazing, that is. So another question coming about, how can a multidisciplinary approach be used to address these issues, and what are some of the benefits and challenges associated with this type of approach?
Well, the first, how I've gone about it is I flagged it to our patient safety. So when I've gone to a patient safety board, I've got these concerns. It is all about research. I will tell you that, because if you don't go with ammunition to say how much it's costing, how long that person's been in a hospital, where's your risk assessment to prove this, your instant reporting, your DATEX. If you've got any concerns about anything, always instant report it, because that's a flag straight away to the board, because they want to know how we're going to improve on that. And then your business case to say, let's say I wanted, I'm going to use this as a scenario. I wanted a bed that does everything for my patient, that I can push a button that width adjusts and does everything that I need it to do, that is extremely expensive. And I know the trust's going to go, you've got on your bike, not having that at that price, but we'll get you this one. So I knew I needed to prove it. So I looked at how many accidents and injuries we've got. I contacted my legal team to see how many legal cases we've had. I looked at how many MSD cases that are legal as well, that are being taken to court for. And then I also looked at how quickly we could move patients. So I started to flag those, and I came up with the answers, went back to the board with how I can resolve this. And they went, okay, fair enough. We'll buy you those beds. And they bought me 12 of them, and they're just about to buy me another 6. So it is proving your case.
Yeah.
Business cases. Maybe we need to have another webinar eventually on how to build a business case, because business case does everything.
I think that'd be very, very helpful. And who would be involved in forming that business case? If once you've done it, where do you take that to?
It goes up to board, goes up to the highest level, because I am the big, again, I'm going to say it, you know, I'm a bit gobby when it comes to, I need answers. I want to go home at night and I want to sleep knowing I fought my ground.
Yeah.
If I can't get the answers I want that patient to feel like my mum, my dad, my sister, my brother. And I know that I've given it everything to get that kit. And if I can't get it, I know I can't do any more. I've done my best. So it would always go up to board. They will always ask a question, but as long as you prove everything. So on your business case, you need yourself as whatever you're working in. So in my case, manual handling, I would need the tissue viability involved. So they do their bit on tissue viability and the issues around that they're seeing. If it's infection control, I need their say so. I want plenty of pictures. I want facts. I want evidence. I want legal saying, well, we've had 4 cases this week. We've had 10 DATEXs, all of that in this business case. We're having it at the minute, actually, just very, very quickly on that. We've got, in our A&Es, we're talking about, and this is something we're doing at the minute, we've got all beds because our patients are staying too long in A&E. And so we're trying to keep them safe, off a trolley, onto a bed. Our space is a nightmare. We physically can't move. Our fire risks are high. I'm sure this is resonating to a lot of people here. So I'm now working on, well, can I find a trolley that could be a trolley bed, pressure relieving? Can we at least put that in there so we reduce the space, but the person's still safe? So is there anything out there? So I'm researching that. That's what I'm looking at. And the trust have gone, fine, you find it, we'll bring it in. So that's what I'm dealing with. And I find that very exciting. I love doing things like that because I love to see the impact at the end.
Yeah, that's absolutely amazing. That's brilliant. Well, we're coming up to 3 o'clock now. Thank you very much for that, Sharon. I've certainly learned so much about that, and looking at the comments from everyone, they're absolutely, everyone's really, really impressed with that, and thank you very much for sharing all that information. So just to finish off, we do have, as Sharon's mentioning about the business case there, we have got resources to help people build their cases in terms of justifications and all that type of things. Obviously, it's only a small part of the whole multidisciplinary approach that Sharon outlined there, but there is plenty on our website to help with building that business case. And thank you very much, everyone, for joining, and really enjoyed that, Sharon. Thank you again for that. And yeah, look forward to another presentation later on.
Could I
Thank
just
you.
say something?
You can, of course.
Graham, could I just, anyone who's still on, I mean, I can see 99 people still, I'll tell you what, this is very, very good. Just for anybody who wanted to know as well, you know, I am one of the directors of the Back Exchange. I'm the conference director of our Back Exchange. We have got conference coming up in September. I will be there. Please do come along, 17th, 18th and 19th. If you want to book stuff on, go online and you'll find us. We are doing our conference this year is hands-on, let's get practical. So it's all hands-on. So it'd be lovely also to see your team there, Graham, if you're not already going, because it is about us working with our exhibitors, our manufacturers, and keeping our patient moving.
Yeah, that's brilliant. Thank you very much. I'm sure we'll be there. It's a very good program. Thank you, Sharon. Thank you very much, everyone else, and we'll see you again.
Bye-bye.
Bye.